Let's talk seizures. So for the next few slides, it'll talk about the objectives, those things. I'm not going to read them to you. I'm going to move on through the slides. The first part of the slides are the slides that you received already. I'll go through those kind of quickly, and then towards the end, I've added slides, and those are the ones I'll talk about. Seizures, disorders, and epilepsy. The chronic disturbance of the nervous system in the brain is what brings on a seizure. And down in another slide, I'll talk about it, but our brain has neurons, and these neurons will produce different neurotransmitters. And with that, if everything is normal and balanced, there is no seizure. So it's when it becomes unbalanced as we start to have seizure activity. There's different kinds of seizures. We'll have focal seizures, which are specific areas of the brain, kind of goes with the focal, and then generalized seizures, which involve both sides of the brain. This just is telling us about focal seizures. We have simple focal seizures, complex partials. There's different things, and as we go along, I'll break these down individually and give you the details of those seizures so that you can identify those seizures and understand those seizures. We have different generalized seizures. Generalized seizures are characterized by bilateral synchronous electrical discharges in the brain. More or less, it's the whole brain is affected, and we'll have these seizures. So as you see the list below, or on this actual slide, you see there's an absence seizure, myoclonic, clonic-tonic, tonic-clonic, atonic seizures, and infantile spasms usually caused by increased temperatures. And I just want you to note on that with the infantile spasms, usually if it's a fever greater than 101, an infant can actually seize. Normally what we see is the higher temperatures when we start to get to 102, 103, and anything above, 103 is usually 104, they're seizing. So what would we want to do to stop that is we would want to bring the fever down. So we could be giving, acetaminophen, an antipyretic, but if they're vomiting with it or they're just so unable to take the medicine, we can go look at suppositories to be able to administer medications, and also cool cloths. Let's take their clothes off. Don't cover them up. Don't bundle them up. Let's expose the body so that we can start to release some of that heat and hopefully bring the fever down. Status epilepticus, I'll go a little bit more detailed in another slide. This does break it down. You can see the information there. I'm not going to read it to you, but I do want you to understand that this is a medical emergency. And so we need to have immediate care intervention that would involve medication administration. As I said, with status epilepticus, we would want to take vital signs, prevent them from injury. That's with any seizure, especially this one. But we would most likely probably need to intubate and have respiratory support for these patients. It is a medical emergency once again. They can have respiratory issues and block off airway due to the seizure. So when diagnosing epilepsy, we need a history of their seizures, what they're doing. Somebody needs to have witnessed these seizures, actual signs and symptoms that have been seen. They'll do a physical exam, of course, a physician, and different tests. These tests can include an EEG, which is looking at brain activity, and a magnetic resonance imaging, which is our MRIs. So we can go and look at the brain and see what we see, which can trigger or identify seizure activity. Also looking at labs, electrolyte imbalances can bring on seizures. And if there are certain imbalances, we need to, of course, correct those. Goes back to your fluid and electrolyte lecture. But we definitely need to be looking at these things. So the treatment for epilepsy or seizures is we want to control or eliminate the cause, of course, if we can, and there'll be some detail I'll break down for you on that. We want to give medications, and this is where it really is important with your patient teaching, is discussing the medications for anti-seizure medications and when to take them, how to take them, what side effects there are with these drugs. They can go on a ketogenic diet. That can help. We see that biofeedback has been proven. We're seeing that also really working with PTSD and some other issues for patients. And there's still a lot of research going on with the biofeedback, but it can help. And then worst case scenario, or sometimes that has to happen, is surgery. And they go in and actually surgically remove parts of the area that are causing the seizure activity. That would be tumors, things like that. On the next few slides, there's observations to make during a seizure. I'm not going to read these to you. Go through them though, because you need to read through looking at different things. I love that here at the bottom it says, which way are the eyes moving? Are they constricting? Are they dilating? Are they deviating right or left or upward? This is going to tell us what areas of the brain are being where the seizure is taking place. So, if it's on one side of the brain, we could see eyes deviate at a different direction. So this is very important to be able to visualize and then be able to report to the physician when he arrives, or if you have to call him to give him the report of what has happened to this patient. For the next few slides, I'm going to just go through them. I'm not going to say anything, and I'm going to get to the slides that I've created. Okay, so seizures are abnormal electrical signals that are fired rapidly from neurons in the brain. We have two neurons in the brain, excitatory neurons and inhibitory neurons. The excitatory neurons are going to produce neurotransmitters, which are glutamate, and inhibitory neurons for GABA are going to produce GABA. And it really is kind of important for you to know this, because as you look at medications, some of them are going to block glutamate and some will block GABA, or vice versa. And so that helps you understand what's happening. When they both are excitatory and inhibitory, and they are exactly what they sound like, something that excites something and something that inhibits something. When they're balanced, we do not have seizure activity. When they're imbalanced is when we start to see seizures. So normal, everything is balanced. So in this slide, I went ahead and broke down what causes seizures, a little more detailed. You've got high fever. Anything over 101 is considered high for an infant. We see febrile seizures mainly in pediatric patients, not adults, but we can have them in adults if the fever gets high. Hypoglycemia, we have low blood sugars. ETOH, or alcohol withdrawals, we're going through DTs. Acid-base imbalances, acidosis will bring on seizures, so we need to look at that. It goes back to your fluid and electrolytes. Hypoxia, we don't have enough oxygen. Brain tumors, of course, are pushing and prodding inside the brain there, which can cause seizure activity. And then central nervous system infections. We see it with meningitis. And with meningitis is one, there's others, but you can have high fever with that also. So these are just causes for seizures. One thing I want to say before I start on this actual slide is also the previous slide, is that whatever's causing it, we need to fix that, or we need to treat that, so that if we take the cause away, we can stop the seizure. And that's kind of what has to happen. Sometimes you can't, and that's where we have to have medicines to balance and create that normal state so that we can prevent seizure activity. Now, for this slide, we're looking at epilepsy. And what defines epilepsy? It's frequent seizure activity due to a chronic condition. So we see it with severe strokes. They could have congenital defects, which cause seizure activity. TBI or traumatic brain injury. They've been in an accident. Somehow they've had this brain injury due to something that's happened traumatically. Bacterial meningitis, I just mentioned that. And it can also be idiopathic, meaning it's unknown. We don't know why they're having seizures, but that's where the neurologist has to step in and start to rule out. And by doing that, then they can give medications, giving and trying different things to hopefully help control the seizure activity. So there's stages of seizures, and you need to know these. Prodromal is prior to seizures. It usually starts day before the seizures, days. They could be a week before a seizure. They'll have depression. They're going to have a change in mood, anger, anxiety. They can have GI and GU issues. They're going to have GI upset, changes in their GI system, constipation, GU issues, incontinence, or they could have urgencies, different things that go on with the body that kind of lets them know they're going to most likely have a seizure soon. So that is called prodromal. Now, not everybody has prodromal the prodromal stage prior to a seizure, but some do. So when you're assessing seizure history from someone that has a history of seizures, you're going to ask them, do you have any signs or symptoms or anything that happens? Do you have any mood swings, anything like that prior to your seizure that you've noted or your loved one has noted? So something to definitely find out. So the next stage of seizures is aura. It doesn't happen with all seizures, just so you know. We see it with focal seizures, tonic-clonic seizures. It's a warning sign that comes seconds to minutes prior to the seizure. They can have altered vision, see spots, hear voices or sounds that aren't present, inability to speak at all, dizziness, anxiety, dread, impending doom, or weird taste or smell. Always ask when you're assessing that history, seizure history, always ask if they have an aura prior to their seizure and what it is. So that's if you're caring for the patient and they say, I'm seeing spots and, I'm having visual changes, I'm seeing things, then you want to go ahead and protect them. You want to keep them safe. So if they're standing and walking with you and they say this, or they just stop talking, then you want to get them down into a lying position, back into the bed, or down into the bed into a rescue position, so that they will be safe instead of falling or hurting themselves during the seizure. The next phase is ictus, and it's actually the seizure itself. Always time the seizure. They usually last 1 to 3 minutes. Anything greater than 5 minutes or back-to-back seizures, they have a seizure, come out of it, go back into a seizure activity, is considered status epilepticus. And needs immediate medical attention. Meds need to be given to stop the seizure, and lots of times we need to intubate and ventilate the patient. So remember that if they keep seizing over and over, back to back, or have a seizure that lasts 5 minutes or greater, then we need to probably intubate, ventilate. We definitely need to give medications so that we can stop the seizure activity. The next stage is post-ictus, and means after seizure or the recovery phase. Tonic-clonic seizures can take days to recover from, but other seizures, they recover immediately, and we will go through those. But post-ictus, normally the patient can be sleepy, tired, confused. If it's the tonic-clonic seizure, they can sleep for days. Headache, they could have injuries from biting their tongue or cheeks. That's during the tonic phase when they tense up. And so you would need to treat their mouth, give good oral care. You always want to, after the seizure is over, do that neuro assessment. So just because they go to sleep, you just don't let them sleep. We need to still assess them, awaken them, make sure they're there, everything's okay, and treat any injuries. If they happen to have a fall or they hit something, those injuries would also need to be treated at that time. So generalized seizures, we have tonic-clonic seizure, which is also known as grand mal. They're most common, is what we see. There's usually an aura or warning sign prior. We always lie them on their side in a rescue position where they lie and the knee is up so that they don't aspirate. We don't want them to vomit or aspirate on any saliva. We want to also keep that airway open. So if we go to that rescue position, it helps prevent any major other emergencies that can take place during the seizure. We want to cushion their head if possible because with tonic-clonic, they're going to have jerking motion and they can hurt their head. And they will lose consciousness. You're not going to be able to arouse them. Some seizures, they're conscious. They know, they see their surroundings. They just have, some symptoms. But with this one, they lose consciousness or can. So with tonic-clonic or grand mal seizures, tonic means muscle stiffening. That's where they do that injury to the mouth. They can have foaming of the mouth with the saliva. They grip down, gritting their teeth, and they'll start to have the saliva foam around the mouth. You'll see that. That is something we can see. Apnea and cyanosis, and these are not good signs. We need to be oxygenating, and perfusing. So we want to watch our patient very carefully. So, if there needs to be emergency intervention, there can be. Clonic is the recurrent jerking, and this is where we can have incontinence of bowel and bladder. So one of the things, especially with children or anybody, but definitely children, we worry about body image. So children that have seizures, if they have one at school, can be very, very embarrassing for them because of the bowel and bladder incontinence, stiffening, how, their clothing, if they're wearing a dress, things like that. We want to provide privacy for them. We want to protect them because it is very hard for them because there's body image issues with this. Also, just so you know, some seizures you can have just tonic, so you just have muscle stiffening, and you can have just clonic, where they just jerk. Post-ictus for tonic-clonic or grand mal seizures, though, they do not remember the incident at all. They're very, very sleepy. As I said, it can take days for them to recover. They're tired and they can have a headache, and they usually do. So absence seizures are the next seizures, and these are petit mal. Most common in pediatrics. They do this staring or daydreaming off. It's often missed because how many kids daydream? I mean, you go into a school, a little thing, if they're sitting there kind of looking off, I mean, kids daydream. So that's why these seizures are missed. But then after a while, they're picked up on and they're looked into and all. They last for only seconds. There's an immediate recovery time. If they're doing something, they can have this kind of daydream off. They come back in, they immediately recover and go back to what they're doing if they're playing with a toy or whatever. They don't remember the incident, so they don't know. They just kind of drift off there for a few seconds and then they're back. But these are called absence seizures, most common in pediatrics. The next seizure is the atonic seizures. They're also known as drop attacks. They lose muscle tone. So they'll have the seizure, lose muscle tone, and they just fall out. And that's why they're considered drop attacks. So if they're walking along, they have the seizure, they stop for a minute, they're just going to fall to the ground. So they go limp or they fall, or they go limp, fall, or slump over. So if they're sitting in the chair, they're just going to fall forward in the chair or slump over in the chair. If they are walking or upright, they're going to fall to the ground. So we want to make sure safety is so important. So think about this. These are the seizures that children have. We see with children, and they have to wear helmets, adults too sometimes. But it's a huge safety issue. So the reason why is what's the heaviest part of the body but the head. So if if we fall out or go, our muscle tone goes away, our head's going to hit first. And especially with children, that's the largest part of the body, right? And it's heavy. And so they hit and can injure themselves. So we put helmets on them to protect them. So if they have these seizures, post-ictus for the seizure, it's immediate once they come to. So once they slump over or fall or go down, once they come around, it's an immediate recovery. They come around. They don't, it doesn't last days or anything like that. The next is focal seizures. We have focal onset awareness or simple partial. They're aware of their surroundings. They last less than 2 minutes. And then we have focal impaired awareness or complex partial. They're not aware of their surroundings and they have motor symptoms are present. Automatisms are motor symptoms. And examples of that is like lip smacking. They just lip smacking or repetitive movement of hands. So that's what we see, that kind of jerking, repetitive movement of hands. So those are the differences of simple partial and complex partial focal seizures. So nursing interventions are huge, and this is what I like to focus on. So for nursing interventions, we always want to assess risk factors. If any of your patients have an acidosis, they're acidotic, they have a fever, they have a brain tumor, any of those issues that we've talked about on that other slide, they're at risk for a seizure, and we need to take seizure precautions. Now, try to get the fevers down. Try to, fix the problem, right? We remove the cause, we won't have the seizure. But if we're prevalent or prone or have seizure history, then we need to initiate seizure precautions. And that includes making sure you have oxygen connected and ready to apply to the patient. Suction is SX, just so you know. Suction is connected ready with a yonker ready, not just sitting in the room, but have it up, on, ready to go. So if you need a suction to clear the airway or at least get the frothing sputum out from the mouth, or if they vomit, you want to be able to clear that. Peripheral IV is PIV and it's patent. We want to check our site. That should be in your assessment anyway. When you come in the morning and do your assessment or throughout the day, you should be flushing that IV, making sure it's patent so that you can provide emergency medicines if needed. Padded rails. If you don't have pads, we can use pillows, different things. You can get creative with it. But you want to protect them from jerking or hitting the rails. Bed in the lowest position, so in case they slump over or if they have a fall, they're not going to fall far. Which we should have all of our beds in their lowest position, period, at all times. Once we finish doing what we need to do, bring it to you so you don't hurt your back, but then lower it back down to lowest position. Remove all restrictive clothing or jewelry. Now, dentures, sometimes what happens is dentures are loose anyway, and they'll be kind of hanging out of the mouth. We don't want anything in there if they're having a seizure. If they're having an aura, you could have them remove their dentures, knowing that they're going to have the seizure. But also, too, if they're hanging there or something, they're an easy grab, get those out. But listen, if they seize, do not put your hand in their mouth. When they go to that tonic, they can clamp down, and they can take your fingers, break your fingers, all of that. You would not want that because they can't release it until it's over. So do not put your hand in their mouth of a seizing patient, period. The next is we want to assess seizure history. If they have a history of seizures, we need to know about it. Last time that they had their medications, what medications they're on for seizures. And if they actually have a seizure, remember, once again, time it from the start until it ends. We need to know. If they have one for a minute, and then the next time one's for 3 minutes, or they have one for a minute and then we're out for a minute or two and we're back in and out for a minute. These times need to be noted and they need to be reported to the physician. We also need to draw labs. We need to get some labs. We want to know a drug level. If you can get a drug level on the medications they're taking, we want to know what their level is. So that tells us, do they have enough drugs or medications in them to prevent the seizure or not? This also will let us know if they are compliant or not. And so this is a good thing to know. And you would just say, would you like me to send a drug level? Do we need to send any lab work down? You have to have an order for this. Do they have an aura, and what is it, so that you can keep them safe prior to the seizure? This has been mentioned before, but if they do have an aura, and I don't care what kind of seizures they're having, I always ask it, because sometimes people can say, well, I have this weird feeling, and it might not, it's their aura, but it's not the classic aura that we say. So I always ask them, do you feel any different? I go into detail of wanting to know right prior to their seizure or days before their seizure, do they have any change in anything? Do they sense or feel anything? Because that is a clue or a key to help you keep them safe and do what you need to do for their seizures. Safety is always first. Safety for the patient, safety for you. So we want to lay them on their side. You want to get them down and on their side. I call it the rescue position. If you're not familiar with it, look it up. It's on their side. And they have their knee pulled up. We put them in this, and it helps keep them from aspirating, and it can help with airway issues. Also, too, if you are trained to keep an airway open, you can kind of just watch to see, make sure they're not going to pull the head down or in a position that would occlude their airway. We would try to keep it open if possible. Do not restrain them, though. Used to, we'd want to hold them down. That old before me, long ago, Florence Nightingale days, I guess. But we do not restrain them. Let them seize. If they're jerking, they're going to jerk. The thing to do is remove items. If there's furniture they're hitting or anything like that, remove it. Put a pillow if they're hitting something hard, because we don't want injury. We want to prevent injury. We used to do these tongue depressing things. There were these padded things, and we'd stick them in to pull the tongue, because they said that the people would swallow the tongue. That helps getting them in that position, rescue position. But we do not do that anymore. We caused more harm to the patient and ourselves by trying to do that. It did not work, and it was not needed. We can do other things to keep airway. Do not insert anything in the mouth. I've said that, and that's safety for you, because if you put and them, because they're clenched down, and if they're not, they possibly could be in a minute or seconds, and you put your finger in the mouth, and all of a sudden they clamp down. So do not. Also, you can injure their mouth or teeth. Remove any glasses if they're wearing. If they wear glasses, take them off, fold them neatly, stick them away so that they don't break their glasses. We all know how expensive glasses are. Airway, always. ABCs, remove any items that could restrict their airway. If they have clothing on or jewelry on, anything that could hurt or restrict them from being able to breathe, we need to remove that. So if they've got a really tight outfit, people wear different things, get it off of them so that they can breathe and not have any issues with their airway or breathing. During their seizure, note what they're doing. This is important. Are they looking up? Are they looking over? Are they turning their head a specific direction? Are they jerking? Are they stiffening? We need to be able to describe this, so you need to assess, look at the clock, assess what they're doing. And also, I put this in here in capitals. Stay calm. You need to be calm. You need to be calm, not only for the room, for the patient's family if they're present, they're freaking out. For anybody else that could be in the room or around, you need to stay calm and do what you need to do. When the seizure is over, you want to do a neuro assessment. Now, they're going to be tired and sleepy. They're not going to be able, but you want them, if they can nod, they can hear you. If they might not be able to speak right away, or they might be a little, garbled. If that's the case, you want to make note of that, and you want to reassess, making sure there's nothing going on that we need to look further into. but they're not going to be able to hold their leg up for 10 seconds and do a full neuro. At this point, we want to know, can they feel us? Can they grip our hands, fingers? Can you look at me if their eyes are, deviated, things like that. But we checking pupils at this point, just making sure they're in there and everything's okay. We want to do vital signs. We want to also get labs. In our labs, we're looking for drug levels for these seizure medications. Now, if it's questionable that they've done street drugs, because there's differences, if they're doing street drugs, then we also need to have a drug screening done. So we could do a drug screen, we can do drug levels for specific seizure medications, and we also want to get a complete metabolic panel because we want to look at the electrolytes. And any electrolyte that's not included in that panel, you might want to add so that when you send that down, you're going to get this data back. And this can help you, see what we can correct or not correct. If they're running a fever, let's make sure we get the fever down. And then, so these are the things that we want to do post-seizure. During or prior to seizure, we want to get the fever down too, and maybe do some screening so we can prevent the seizure. But if we have a seizure or someone comes in and there's a seizure all of a sudden, these are the things we want to do once the seizure is over. EEG is we assess the electrical activity of the brain. It's a test that's done. Electrodes are placed on the head. There's a lot of them. There are actually technicians that come in and do it. They're very trained and know, but it's painless if the patient asks you, does it hurt? It does not. It's just kind of bothersome. You have all those electrodes. They can't mess with them. They have to be still. No, they can move around in the bed, but we want them to be as still as possible so that we can get true readings of brain activity. No caffeine because it's a stimulant. We don't want any stimulation, added stimulation. We want to see what the brain's really doing without it. Hold all seizure medications prior to the test and then give after, but definitely clarify this with the doctor. Get an order to say hold the meds prior. Sometimes it's in a protocol, but definitely clarify if you don't have a written order, hold the med prior to the EEG and give the med after. Also clean their hair and comb their hair. If they've not had their hair combed or their hair is dirty, oily, the electrodes are not going to stick. They're going to have trouble with the scalp and getting those electrodes to stick. So definitely have clean hair. Now, if there's stuff going on and you got to get an EEG and it's just a matter of seconds, you're not going to be able to wash their hair. You need to understand that. But if they've been in the hospital and they're having these problems, get their hair clean so that when their EEG, it's time for their EEG, they hopefully can get the electrodes to stick. Most of the time they can get them to stick though, I can tell you that. So the key to anything with seizures is to avoid a seizure. And the way to do that is, and these are the things that can cause seizures, and so stress. So let's decrease our stress levels. Trauma. Trauma is something, let's just not have an accident, right? Wear your seatbelt. If you're on a bicycle or a motorcycle, wear a helmet. If a child is out riding on anything that rolls, that was my rule of thumb. If it moves, put a helmet on, because my kids would create things and they'd be like, well, it's not this, Mom. You know how they are. So it was, if it moves, put a helmet on to protect that head. Change in hormones, pregnancy. Also, menopausal hormonal change can bring on seizure activity. So we need to look at, note that can happen if we have an influx of hormones due to pregnancy or female hormones. Birth control also is another. That's a hormonal. We're dealing with female hormones there. Overexertion. Let's not overexert ourselves. Loss of sleep or deprivation. You need adequate sleep. People that don't get adequate sleep, they go sleep deprived, they can have seizure activity. Acidosis, let's correct it. Is it metabolic or respiratory? Let's correct it per whatever's going on. Go back and look in your fluid and electrolytes and look at those signs and symptoms. Hypoglycemia, low blood sugar, dehydration. If they're under medicated, they didn't take their drugs, or no street drugs or alcohol. Let's prevent a seizure.